Mukherjee is happy that NaON is not happening with semaglutide. Until 1 month back, he used to tear my hair every now and then. Then I showed him an editorial which I wrote in Japi in last month. He was a little bit, consolable. Now I see his face, he is happy that this data was presented. Okay, so let's shift gears from obesity to liver disease and semaglutide. This is a Novo-sponsored symposium, but all slides which I will present is, edited by me. You know why we are discussing this topic? Because we have to be dependent upon this. This is an era where we need to discuss obesity. If I look at the face sitting in hall, if you yourself don't diagnose as a obese people, go to a weighing machine, measure your waist circumference. By any of your measurement, 99% people sitting in this hall will be defined as obese people. Straightforward, including myself. I would be perhaps morbidly obese. At least I was. I have improved a lot. Now, if you put a fibroscan on your liver, everyone, and I bet you, everyone would have some degree of osteosis, and I would not be amazed to see even fibrosis. So let me share my experience quickly. In this last DiaObecon, in the month of July, we put a fibroscan to everyone attending DiaObecon. That consisted of more than 2,000 people, including doctors, as well as non-medical people, those who works at ITC, Royal Bengal. And we have incorporated all data in my laptop in an Excel sheet now. I don't have the statistical calculation, but from the rough eye, I can tell you that I was amazed to see that perhaps all of us in this hall is suffering from a moderate to severe degree of osteosis. That is amazing, shocking. I would not believe that one of my friends who never touch alcohol or anything, and he's having a BMI of 21, has a grade 1 fibrosis, F1 category. Shocking data, which how it is happening, why it is happening, is really need to see. And next 2 days in this meeting, you would see Bansi has arranged all the meeting on obesity. I could see Dr. Narvaya moving with a scalpel. He will lose the job of a bariatric surgeon because now we have got a tools in our hand. And every day we'll be getting a better tools in hand in the next 2 to 3 years. So let's dissect why liver disease, obesity and semaglutide and beyond is important too. This is a Novo-sponsored meeting. Needless to tell you, everyone in this room has read past MBBS course knowing that if you have got a fatty liver disease, if you don't intervene, it will develop to osteohepatitis, then fibrosis, then cirrhosis. Once you are in a stage of cirrhosis, you can't return it. It is an irreversible state. So until the stage of F3, third stage of fibrosis, you can revert back into the liver. And remember, cirrhosis is just not ascites, it's a hepatocellular carcinoma. And there is no treatment for that. So today is the era where we need to talk about this disease, which is really treatable and reversible. Good thing is that even 1/3 of liver, if it's intact, you can recover the entire liver. The only organ in a human body which is completely replaceable is the liver. So this is such a hard organ that you can reverse it back, but before that you need to know that you are suffering from the liver disease. Needless to tell you the amplitude of the problem across the world. Look at the data, everyone. Look at the global data, including the South Asian. You might be thinking our people are poor. Look at the prevalence of fatty liver disease, MSLD, touching the Latin Americans who based on only pizza and burgers. We don't have rice and chapati to eat. Still we have got a metabolic associated liver disease. So we need to take care of this. And the reason being is the obesity. That's the key driver. And not only obesity, if you have got a MSLD or NFLD, it is associated with diabetes, hypertension, hyperuricemia, metabolic syndrome. You need a tool that not only correct the fatty liver disease like resmetirom. Resmetirom cannot reduce body weight, hypertension, dyslipidemia, although it does lower LDL level. So you need a drug that takes care of everything. You go to a big, bazaar and you buy one, get one free. You get treated with all the disease, and therefore the GLP-1 comes at the hit list in this MSLD space with obesity and metabolic disease. Needless to tell you that these are associated conditions where GLP-1 works, and we have enough Himalayan evidence today. GLP-1 is the first line drug in people with diabetes, with established heart disease, kidney disease and heart failure, along with a SGLT2 inhibitor. So what we were waiting for? We were waiting for a molecule. Remember, none of the drug in the planet has got approval for MSLD except resmetirom, which is not available in India. Resmetirom, as you know, is a TSH receptor alpha agonist which works through liver, not available in India. The tablet cost nearly $10,000 per month. It's okay. India is now no longer a poor country, we can afford that. But you only treat liver disease, you do not treat the accompanying disease like blood pressure, obesity, dyslipidemia and body weight. Now, therefore, we need a tool that has to take care of everything along with MSLD. In this region, semaglutide underwent a double-blind randomized controlled trial in people with MSLD, which is histologically proven. So you can see nearly 1100 patients who had a baseline histology liver biopsy data. They have got a part 1 and part 2 of the trial. I will present you the part 1 data. Part 2 is continuing. So you can see this is a 1.5 year trial. The 4-year trial is currently under progress, which has got a hard endpoint, means liver transplantation, cirrhosis, etc., etc. This is a relatively softer endpoint, resolution of osteohepatitis, resolution of fibrosis. So these are histologically proven MSLD. They were randomized to semaglutide 2.4 milligram in a step-up fashion from 0.25 to 2.4 milligram compared to placebo injections of 2.54 milligram, equally matching injections. They were randomized 2:1, means more people. That's what the FDA suggests, that if the drug has a potential to prevent liver disease, obesity, diabetes, hypertension, then you have to allow more patients ethically in the active arm compared to the placebo. So that's the part 1 of the story I'm presenting. The primary outcome was to look at this osteohepatitis resolution with no worsening of liver fibrosis at week 72. And another co-primary endpoint was improvement in liver fibrosis with no worsening of osteohepatitis at week 72. That's the 2 primary endpoints. The part 2 is, as I said, it is undergoing. We don't have the data. That's even a harder endpoint, hepatic decompensation, liver transplant for next 4 years. These all 1197 patients are currently undergoing trial. Let's look at the result. You can see there are nearly twice percentage of people had resolution of osteohepatitis. You can see nearly 1.5 times people had a improvement in liver fibrosis without worsening of osteohepatitis. And this data is twice larger than the resmetirom data. That is Mastro-NAS study done with resmetirom, which has got the approval for MAS. This benefit is almost twice larger compared to the resmetirom. That point I am trying to raise, and this is the reason semaglutide has been given approval on 15th August in people with MSLD. Now, if you look at the co-primary endpoint, resolution of osteohepatitis with improvement in liver fibrosis, you can see nearly twice percentage of people had achieved this secondary endpoint, which is osteohepatitis resolution with improvement of liver fibrosis. Again, this data, if you go and look at the Mastro-NAS study of resmetirom, is twice larger benefit compared to resmetirom. Needless to tell you that if you are using semaglutide 2.4 milligram, you have got buy one get 10 free along with MSLD. So it's a 10 big bazaar put together. Now I will next 3 minutes, I will quickly take you through beyond weight reduction, beyond cardiovascular outcome and liver disease. Wegovy or semaglutide has been studied exclusively in people with pre-diabetes, called STEP 10 trial. You know, STEP 2 was a diabetes trial. This was exclusively done in people with pre-diabetes. They were randomized either to semaglutide 2.4 milligram versus placebo. Needless to say that nearly all reversed to normoglycemia. This is not shocking, surprising, it has to be there. But this is the data evidence generated. Semaglutide is not yet licensed for treatment for prediabetes, but this data speaks volume that if you lose weight, you can revert prediabetes to normoglycemia. Semaglutide has undergone an exclusive trial called a step 9 in people with osteoarthritis. Everyone had osteoarthritis. They were randomized to semaglutide 2.4 milligram versus placebo. Look at the result on different scoring system done primarily by my orthopedics colleague, suggesting a significant improvement in the walking, cracking of the joint, etc., etc. So that's exclusive study conducted in a step 9. So if you have got a patient, Dr. Saab chal nahi pati hu kuch kariye, you have got a evidence-backed data with you to use it. Now I will quickly take you through SELECT, which previous to a speaker present, but I will give you a very interesting graph, and any presentation meeting would be incomplete without looking at this graph. So Dr. J.J. Mukherjee said he was surprised how benefit happened in the STEER trial within 8 months. But he himself presented that benefit happens as early as within 3 months. How it is happening, why it is happening? If you look closely at this data, the benefit, so this is the middle one is the, the mean HR, and the both orange one is the upper bound 95% and lower bound 95%. If it is less than the unity, means this line, means you win the match. You can see this graph when the trial started. Within 20 days, you can see this upper bound came down to less than unity, that is less than 1, suggesting that drug has a potential to give you a benefit within a month, within 20 days. And that started persisting by 3 months. After 86 days, it continued until next 4 years of the trial. Remember, SELECT is a mean 4-year trial. And it never went up, crossed the line of unity, thereby giving you a suggestion that within 3 months, you get a cardiovascular benefit. Even before you lose body weight, by 3 months, you are still on 1 milligram of semaglutide, from 0.25 to 0.5 to 1 milligram. Yet you have got a benefit. That's the beauty. And if you correlate with the weight, so people said if you lose weight, you get the cardiovascular benefit. You started having a cardiovascular benefit when the weight loss was less than 2.5%. Thereby suggesting, and Dr. J.J. Mukherjee told you, this cardiovascular protection with semaglutide is not directly related to the weight loss. So interestingly, the weight loss happened exactly at 6 months in the SELECT trial, and you can see the benefit started quite early before the weight loss. This suggests that the cardiovascular benefit of semaglutide is not fully, maybe it could be partially related later on, but why within 3 months when the weight loss did not start? And if you look at the individual endpoint, look at the MACE within first 3 months, this came down to the left of the unity. So within 6 months, you have got a MACE benefit. And within 6 months, you have got all CB, death, etc., all other secondary endpoint. That's the rapidity of benefit. Finally, what about the heart failure data? Do you have any trials of GLP-1 or semaglutide in heart failure? You know there are 2 dedicated trials done with semaglutide 2.4 milligram in people with obesity, that's called a step heart failure preserved ejection fraction, and people with diabetes called heart failure preserved ejection fraction diabetes. These are soft endpoint trial. As you can see, this is KCCQ scoring, and there was a significant benefit in people with obesity and people with diabetes without obesity. So that's one of the primary endpoint of this 2 trial. The another co-primary endpoint was the 6-minute walk test, and you can see in both obesity and diabetes trial, there was a significant benefit. So these are soft endpoint. What about the hard endpoint? Was there any heart failure hospitalization benefit or CB death benefit? So what they did, they pulled the data of the 5 trials, SELECT, FLOW, STEP, heart failure, obesity, STEP, heart failure, diabetes, and they looked for the hard endpoint, that is CB death and worsening heart failure, and you can see there was a 31% relative risk reduction in the composite of CB death, heart failure, hospitalization in people with heart failure with preserved ejection fraction. So what did we learn? That semaglutide is first GLP-1 or anti-obesity medicine to receive a label update for reducing fibrosis in MSL. Only 2 drugs, resmetirom and semaglutide. You might ask me, what about tirzepatide? Tirzepatide has undergone a phase 2 trial called Synergy NAS, and is not undergoing a phase 3 MSLD trial. So they will never get any level update for MSLD. There is no trial under progress with tirzepatide in people with MSLD. They are doing trials with retatrutide phase 3 trial in people with MSLD. So the only drug in the GLP-1 or GLP-1 GIP space at the moment and perhaps in the future is after resmetirom is semaglutide. Remission of pre-diabetes you saw through the step 10, same data is there with the tirzepatide. Semaglutide is the first AOM till date. We have to wait for Surmount MMO, which will not come before 2027 end. So until next 2 years, the semaglutide would enjoy this space in people with obesity and established cardiovascular disease. They have got a dedicated trial in osteoarthritis. Tirzepatide has got a dedicated trial in obstructive sleep apnea, which semaglutide doesn't have. So there tirzepatide wins over semaglutide. In osteoarthritis, sema wins over tirzepatide. And with regards to the heart failure and CB death, you would expect a soon level update for semaglutide. They are currently under hammer with the FDA to get a preserved ejection fraction level update from the US FDA. So that's all the data from my side. Thank you very much for your patience listening.